Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Health Leader Forge is a production of the University of New Hampshire's College of Health and Human Services. This week's guest is Tim Soucy, the director of the Manchester Health Department. Tim started in the department as a sanitarian and worked his way up to be the director in 2006. In this podcast, Tim talks about his 25 years of service to his home city, how the department has evolved, and the challenges and opportunities public health workers face every day trying to make Manchester a safer and healthier city. Welcome to the Forge, Tim.
Thank you.
So you're originally from Manchester. Grew up here?
Born and raised, yeah.
Okay.
So it's nice to come back and actually serve the community that you grew up in.
Yeah, okay. So tell me a little bit about Manchester. What was it? How has it changed over the years since you were a kid?
You know, it's really changed dramatically, I think, for the good and for the bad.
Okay.
Manchester's interesting in that it's a large enough city to have some real problems, but still small enough to get your arms around. You know, the city has certainly changed. You know, we see a lot more poverty right now. About over 54% of the kids in Manchester schools are eligible for free and reduced meals. So the rates of poverty and childhood poverty. You know, Manchester was a sort of a very blue collar working community, and we see much more poverty now than I think we ever have, and that's certainly concerning.
Is that a change in industry that's here, or?
Well, we went through the city really went through a tough period in the 60s, 70s, early 80s with the mills. You know, Manchester used to have the largest industrial mill complex in the world in its heyday, and I think when the mills declined, a lot of people lost their jobs. You know, we had this sort of banking crisis in the 80s where a lot of the banks were taken over in the city. But now we're seeing much more high-tech, redevelopment of the mill yard. So there are some really great things going on in the city.
Is the high-tech thing relatively recent, or is it like in what span?
Yeah, really over the past 10 to 15 years, It's really taken off. The mill yard has been redeveloped. There's been a lot of work to redevelop Elm Street, which is the main thoroughfare in the city. The Verizon Center, the Fisher Cat Stadium, all these things were done recently within the past 10, 15 years, and they've been really great things for the community.
Okay, great. But at the same time, you're seeing high levels of poverty in the school system. So is it that families that were here that were employed in blue-collar kind of work haven't made the transition to the new kind of opportunities?
We still have a pretty transient population, so it's hard to say there's one cause, for the rate. I think it's kind of a number of factors that have all played in through the years, and it's one of those trends we've just got to reverse, and it's not going to happen overnight.
Right. Now, how big is Manchester?
The city proper, it's about 110,000 population. Area-wise, it's about 33 square miles. It's pretty neat to have this urban center in a rural state. That part of it is cool, is that we have this urban center where there's activities and restaurants and all these other great things going on. But when you take Manchester versus the rest of New Hampshire, it's a very different face. We talk about New Hampshire being one of the healthiest states in the nation, and all of these really great things. Low birth weight baby numbers are very low, and but when you look at Manchester, we don't look like the rest of the state.
Okay.
We tend to overrepresent a lot of the negative factors. But it's
is that because it is the largest city in the state?
There's no doubt. It's because it's an urban center. A lot of people come to the city for services. Which getting back to that other question about why are our homeless numbers so high or poverty so high? Manchester is a draw for people coming to access services. We've got a great system of nonprofits, of churches, of people who want to help others, and I think that helps draw folks to the city.
Okay, and. What I've heard that Manchester, I've read that Manchester is a refugee center?
It's a refugee resettlement center.
What does that mean?
So every year the United States takes in around 80,000 refugees from refugee camps, and Manchester has been designated as a refugee resettlement area by the resettlement agencies. So there's two prime resettlement agencies in New Hampshire, the International Institute of New Hampshire and Lutheran Social Services. So Manchester has always received sort of the bulk of refugees. And when I say, we're probably talking in the average of 200 to 300 per year. And they've come through the years from many, many different countries. Really started many years, probably 20 years ago with the Vietnamese population. And then we had a large influx of Bosnians,
Interesting.
all around the,
That's
the wars.
quite diverse.
Yeah. Then we had a very large influx of Africans. And now our greatest group of refugees is the Bhutanese. It certainly adds a lot of diversity. We have over 70 languages spoken in the school system.
Wow.
In Manchester. Poses its challenges. There's no two ways about it. And there's always been this debate in the city about refugee resettlement and are we doing the right thing by bringing people over and over without making sure that those who have already resettled have become acclimated. And that's sort of the debate that rages on. I don't think anyone, has any issue with the refugees or the value they bring to the community. And our mayor has said through the times, just let us catch our breath and make sure that everyone who's here has learned English, has gotten a job, has had the opportunity to succeed. And we've seen a number of success stories, but sometimes when folks arrive, it's, do I learn English or do I get a job?
Right.
And
Sure.
take care of my family. So it's pretty unique. We run refugee clinics here. We're actually one of the first stops that a new arrival makes when they get to the city.
Okay.
We'll make sure that they at least get started on their immunizations, because quite often folks don't come in with great medical histories and records. We'll do TB testing on folks. Our goal is to get them what they need right away, make sure that the public health is protected, because we do have folks who come in with latent TB infections, so we need to make sure that they're put on appropriate medication, and then get them linked up with a medical home, a permanent medical home. So we're not their medical home, we're their first stop, and then most folks end up at the community health center or the Westside Neighborhood Health Center for their long-term care.
All right, well, we'll come back to the refugees, I think, in a little bit, the refugee care in a little bit. But I want to ask you a couple more questions about Manchester real quick. So let's imagine you're now the ambassador for the city. Why do people come to Manchester? What's great about it? What are you particularly, as a son of the city, what are you particularly proud of when you tell people, I'm from Manchester?
Yeah, it was kind of a funny debate, because I grew up in the city, I still live in the city. Manchester's got a lot going for it. It really does. It's got a thriving downtown. It's got great arts, culture, restaurants. As I said, we've really kind of turned the corner with some great high-tech jobs. You have companies like Dine and Deca and Silvertech that are, big employers, really recruiting, trying to get that younger generation to move into the city. My kids went through the public school system. I think we have a great public school system here. It takes a lot of knocks sometimes, but I think we have a great school system. The fun thing about Manchester is you're an hour away from Boston, you're an hour away from skiing, you're an hour away from the ocean, so it's a pretty cool place to be.
Great. And you went to UVM.
I did.
And you studied biology. When did you get interested in public health?
Well, I kind of fell into it by accident, to be quite honest.
Okay.
When I graduated from UVM, my first job was doing contraceptive research and development down in Worcester, Mass., which wasn't really what I had in mind, as a long-term career.
Okay, interesting.
But it was pretty interesting. We actually did the first clinical trials on animals with what's known now as Plan B, the morning after pill. So I guess that's my claim to fame. I'm not sure.
You were part of that.
Part of that, yes. And actually, a position had opened up with the health department as an entry-level health inspector. And once again, they were looking for someone with a science background, which I had my bachelor's in biology and applied and was hired, and that was in 1990, and 25 years later, I'm still here.
So how did you? You found out about this position. Why did you apply? Why didn't? You already had a job.
Yeah.
You were working on interesting research. I imagine.
Well, yeah. I didn't realize I was allergic to rats until after I started. But it was an opportunity to do. I'm not a person who wants to sit in a lab. With the same 3 or 4 people day after day. I love being out and about. In the community and doing different things. So it was an opportunity to sort of take that science background and apply it in a number of different ways. was a little bit more money. It was a chance to move back to Manchester, so everything kind of fell into place.
I understand that, wanting to come home. So your first job was an environmental specialist / sanitarian.
Right.
Is this a typical kind of entry-level job in your department?
Yeah, it is. It's
So what does it do? What did you do? What were your
yeah. So at
responsibilities?
at the time we used to call them sanitarians, and now over time I think we've made the transition to environmental health specialists, a little more professional sounding.
All right.
I remember my wife giving me a hard time when we put our wedding announcement in the paper because it said sanitarian. She said it sounded like I threw garbage for a while. So yeah, we hire quite often folks right out of school with their bachelor's degree for this position. It's a health inspector, so I spent a lot of time learning about food safety, inspecting restaurants, doing different complaint investigations, and that's always interesting because that's everything from checking on people's living conditions to garbage in the alleys to answering chemical questions to radon. So we really looked at some of how the environment interacted with public health, and we designed a lot of programs around there. So it was really a lot of inspections, a lot of field work. Became a septic system designer because we still have a little bit of the city that's still on septic systems.
Okay.
So I still maintain my septic system designing license, even though the technology has changed. I haven't quite kept up with everything through the years. So it's a lot of field work, and back in that time, the bulk of it was around food safety, and we still have a very robust food protection program.
Okay. How many environmental specialists do you have today on staff?
Yeah, we've got 5 people in the field.
Okay.
So,
so that's not a huge force.
No, it's not.
For a fairly large city.
It's not.
110,000 people. You've got 5 inspectors.
And they're busy. They're busy folks.
Bet.
Yeah.
I bet.
Yeah.
Okay. How did you go about? So you had a degree in biology.
Mm-hmm.
Clearly, you probably never, I'm guessing, never done a food inspection before, amongst other things.
That's
all these other
correct.
things. How did you learn your trade?
Yeah, a couple different ways. Yeah, a lot of on-the-job training. Really, we always say we want people with a sound science background, and we want people with good interpersonal skills. I can teach you how to do a restaurant inspection,
Right.
but we've got to have the right attitude because you deal with a very diverse group of people, from restaurant owners, business owners. You're in people's homes, you're doing these things. So we need people to understand the science of what they do, and then how do you apply it in a manner around food protection that you're able to say to someone, this is the violation because here's the science, not because the code says so or because I told you to do this, but really being able to explain why we want people to do certain things.
Okay. And that's important because
we want people to understand what they're doing. We don't want someone to just say, this is dirty, clean this food's out of temperature, whatever. We want people to say, you can't have food at this temperature because bacteria is going to grow and you only have so much time, and put it in ways that people understand why it's important.
Okay. All right. So after 4 years on the job as a inspector, you moved up to be the chief of the Division of Environmental Health. Can you talk a little bit about the mission of the Environmental Health Division?
Sure. So at that point I was promoted to oversee the other inspectors, which was an interesting time because I had worked, these are the folks who had trained me that I was now supervising, which is always a challenge when it comes to personalities. But it was interesting. At the time I was taking some additional home study courses from CDC, trying to sort of broaden my horizons as well. And I get to do a little bit more administrative work, a little less field work, but still some field work. I still actually to this day keep my hand in some of the field work, which is kind of interesting.
Okay.
I tend to take the bulk of the weekend and night call, and instead of calling someone else out in the middle of the night, I'll just handle whatever comes up.
Okay.
Yeah.
So you were working as an inspector. You got selected to move up to be the supervisor. How did you learn the leadership elements?
Yeah,
was that also kind of an OJT thing?
It was kind of OJT. Okay. At the time there were a couple other supervisors, nursing supervisors that I was, would learn from them, and I tend to try and, I guess at least in my own mind, pick the best from everyone and develop my own style. But seeing what I think has worked for others, will or will not work for me, and I try and keep things pretty simple. I try and treat people fairly, evenly, consistently. I have a very open door policy. It's not uncommon for anyone to pop in. It's always been that way. A lot of the leadership skills I think were really based on observing others and what I thought would work well for how I was going to run not only my division but interact with the public.
Great, great. Has this mission of this division changed since you were in charge?
The overall mission hasn't changed. I think some of the tactics and strategies have changed. Technology changes. There's always new. I mean, when I started, things like West Nile virus and EEE, we didn't deal with. It wasn't an issue. Now we have a very robust summer program where we're trapping mosquitoes. We're doing a lot of public relations with the community around personal protective measures. 25 years ago, we just didn't do it.
So the scope of this department is not just food inspections, and it's also including contagious disease or the spread of.
Correct.
Okay.
Yeah, that's really our bread and butter. When you look at public health, is we have another division of community health nursing, which handles all of the communicable disease investigations. And some of them are preventable, some of them are not. Some of them the report comes in, you drop what you're doing and make sure that gets addressed right away. Right. It's not uncommon to have a number of active TB patients in the city at any given time, so our staff works 365 days a year doing directly observed therapy on someone to make sure that they're taking their meds. We don't want to develop drug-resistant TB. We want to get people healthy and back to a normal life as quickly as possible.
So in a day in the life of a health inspector or the chief of the environmental division, what could that person expect to be out looking at?
It varies.
Food inspections, trapping mosquitoes. What else?
Swimming pool inspections.
Okay.
So we license and inspect swimming pools in the city.
Is that a public pool or like somebody's house?
Anything not attached to a single-family home. Okay. So condo associations, public pools, hotel pools. Okay. So we'll be gearing up for that in the springtime. Everyone gets a sort of pre-opening inspection. Different complaint investigations. We've actually, believe it or not, been doing more and more investigations around hoarding. Hoarding.
Okay. Talk about that. That sounds interesting.
It's we see quite a bit of it's for a number of different reasons. Sometimes you have someone who has mental health issues that just refuses to.
So this is someone gathering up a lot of stuff.
Yeah.
Okay.
Yeah. Sometimes.
And when does that become a public health issue?
Well, it depends. It's a thin line because there really needs to be something there that creates an imminent hazard. So, if someone just has clutter, newspapers, clothing. We'll try and get them some assistance. When we get into rotting food or sewage disposal not working properly or animal feces, then it becomes much more of a imminent public health threat that we have some pretty substantial legal powers that we can enforce when we need to. But, we always consider ourselves educators first and enforcers second. We do have the legal tools when we need them. Okay. But if someone is in that position and it's because they need help, we're there to get them help first.
Right. That sounds very interesting. So I was looking at your CV, mm-hmm. and I noticed in 1998 you received your master's in public health from Boston University. How important is getting a graduate degree to practice in your field, particularly at the level you're now at?
Yeah, I think it's pretty important. An MPH is such a broad degree that it opens. Not only does it open a number of different doors for students, but it's kind of a hands-on degree. So I think it's important. It was interesting because I started going to BU in '95, so I was still working full time. My wife and I had just had our first daughter, and I was traveling to Boston 2 nights a week for 3 years. So it was a little hectic time, which I'm so happy that UNH has put the MPH program in Manchester now, because at the time there weren't a lot of options for people to get an MPH, and I think it prohibited a lot of people. I think we're seeing a lot more people in the field of public health and healthcare going back to get an MPH because it's much more accessible. So, for growth opportunity, for job opportunity, for personal development, I didn't want to do environmental health every day for the rest of my life. It was fascinating, but it was time to do something different and learn a new skill set.
Okay. Also looking at your CV, it's interesting to note that up through about 2000, your continuing education had titles like food microbiological control, safety measurement, bloodborne pathogens, and introductions to indoor air quality. And then post 9/11, some of the titles of your continuing education include emergency response to domestic biological incidents, biodefense mobilization, healthcare leadership and administrative decision-making in response to weapons of mass destruction incidents. So how did public health change after 9/11?
Yeah, it's a very different world now. It's an interesting debate because after 9/11, there was an influx of money into the public health system.
Okay.
I think we realized after 9/11 and after the anthrax attacks in October of 2001 how deplorable our public health system was across the country.
Really?
Yeah. Okay. So the federal government, went from a couple $100 million to billions of dollars investing in public health infrastructure around the country. And we were the recipient of a lot of that funding. Our first emergency preparedness grants just for the city were over $1 million a year. We're down to about 400,000 now, but it was a tremendous influx of money. And different health departments across the country handled it very differently. Some people put all their eggs in this emergency preparedness basket, and there was a lot of criticism about we're really forgetting what public health is all about and just solely focusing on emergency preparedness. We took a lot of that funding and we shored up our staff. We brought a medical director on, which we had not had for many, many years.
A medical director meaning a physician?
A physician on staff. We've always contracted
Okay.
with a physician for things like standing orders, but to have, we realized that we really needed to make a much stronger link with the medical community, and docs tend to talk to docs better than public health directors. So we did bring a physician on and kept that position filled for a number of years. One of the other interesting things we did with post 9/11 funding is we created a training institute here at the health department. We realized New Hampshire doesn't have a very robust local public health system. There's the city of Manchester, the city of Nashua that have health departments, and there's about 15 what we call self-inspecting towns, meaning they do food protection work and environmental health work. And then the rest of the state, every town has a local health officer, but that's it. And the only requirement to be a local health officer in New Hampshire is that you're a resident of the state of New Hampshire.
Oh.
So there's
qualifications are varied.
Varied, yes.
Is that a nice way of saying it?
That's a very nice way of saying it. So what we've tried to do is put together this training institute, and it consists of 5 courses. There's an Intro to Public Health course, an EPI course, a communicable disease control, an environmental health course, and an emergency preparedness course. Each course runs around 6 to 8 weeks. They're Thursday mornings from 9 to 12. And it was an opportunity for us to begin to use the expertise that we have in-house to provide real hands-on training. So our EPI and biostats is very different than what you would take at the undergraduate or graduate level. It's very simple, but easy to understand, much more applicable than just sitting there doing biostats.
Well, you're not doing research.
Correct.
Right? You're not preparing people to do research.
Exactly. So we used some of that post 9/11 money to create this training institute, and we've had a couple hundred people complete all of the courses.
Wow.
So that was one of our ways of helping
Who
build.
comes to these classes?
It varies. We have folks in-house from other health departments. We have a lot of folks who come from hospitals. We have folks that come from DHHS. We have local health officers. So it really varies, and I think that's what makes for an interesting class. Is we've got people from a variety of backgrounds and experiences that are able to share and learn.
Wow, very good. So, in conjunction with 9/11, your title changed. You became the Public Health Preparedness Administrator in 2002, and it looks like that was an expansion of the chief of the Environmental Health Division.
Yeah. So what happened was we really began to put a lot of work into after 9/11 into the development of emergency preparedness plans in the community. We work very, very closely with our first responders, our fire, our police departments, our EMS provider, our 2 local hospitals, to make sure that we put in place plans that made sense, to respond to an emergency, whether we always say, whether man-made or naturally occurring, because we've seen both. So a lot of time was spent developing these plans, drilling these plans, executing these plans. So it was an expansion of my current job. I got a longer title out of it. But it was good because we did have all of these resources coming in, and we needed to better coordinate what we were doing.
Okay. Was this the first time you had worked with the Manchester Emergency Operations Center, the EOC?
Yeah, typically
Did an EOC exist before that?
It did. It was managed very differently than it is now, for certain. We still had dealt with flooding incidents, snowstorms, power outages,
Sure.
the natural disasters, prior to 9/11, and that's still the bulk of why we sit in the EOC. But I think we've seen much stronger relationships built amongst the city departments that in response to emergencies now. It used to be, I think everyone had their own little piece of the pie and they didn't necessarily want to share that, and now you see a lot of group decision making. We often joke that sometimes the community police officers are more like public health guys, and so we've done a lot of cross training with fire and police and through the years, and I think those relationships have really been stronger and put the city in a better position should we ever need to have to execute any of these plans.
Okay. What did you learn in the process? So there was a lot going on back in that time frame. A lot of fear, a lot of resources were suddenly becoming available. What did you learn in terms of kind of what worked, what didn't work?
I think I think what worked were the relationship building. I think everyone realized that we were in a new time and that they couldn't keep their little piece of the pie anymore. That it was really about if we were going to work better, it had to be collaborative, and I think that was really probably the greatest thing that came out of that. It was a really tumultuous time. I remember after, two things that come to mind. The mayor at the time said to the fire chief, the police chief, and the public health director at the time, make sure the city's prepared. Well, what did that mean? We didn't know what that meant. So
did he know what it meant?
No one knew what it meant, but it was a good soundbite. It's what we had to do, and I think because of some of the relationships we've built over time, particularly with the hospitals, we've been able to engage them at a new level. Not only around emergency preparedness, but around community health and what are they doing in the community and how do we better utilize them in the community. And it's not only about writing a check, when we need some money, it's about how do we better partner to improve the health of the community. So I think the relationships that were built have put the city in a much better place.
Great. Do you worry about complacency? I mean, we've had some time now.
I guess you always worry about complacency. I think on the, on the infectious disease side, there's always something new popping up. Right. We keep this response kit of personal protective equipment, and it started with smallpox. If you remember, during the first Gulf War, there was quite a concern that smallpox was going to be used as a biological weapon. So we had the smallpox response kit. Well, then that threat passed, and then monkeypox came up. So there's a new sticker on it that says monkeypox response kit. And then SARS came up, so there was a new sticker on it that said SARS response kit. And then H1N1 came, so it was a new sticker that said H1N1. And Ebola came as a new sticker. So, there's always something new coming up. I think when you look at the threat of terrorism, it certainly has not gone away. I think complacency happens when these things are left to the side. I think we still try to be pretty active. We have a regional public health preparedness advisory council that still meets.
Okay.
So, I think everyone
that goes beyond Manchester.
It goes beyond, yeah. When we look at emergency preparedness, we realize it doesn't respect geographical boundaries. Because there's really no local public health infrastructure outside of the city, we try and help provide that service to our neighboring towns during emergencies. I mean, we don't do it on a routine basis, but we do plan regionally because, an influenza pandemic in Goffstown is the same as it is in Manchester. And so we've developed some pretty good plans around things like points of dispensing. If we had to provide a vaccine or an antibiotic to a large number of people, how do we do it? And we've worked with the towns of Bedford and Goffstown to set up these pods. So a lot of good regional work has occurred as well.
Okay. We've been talking about public health, but I haven't actually asked you to kind of define it for us. So could you give me an idea? What does it mean to you? I think this is a term that means a lot of different things to a lot of different people. What does it mean to you as the director?
That's a very good question, because we've spent a lot of time talking about environmental health and emergency preparedness, which is a very small piece of what public health is. In my mind, public health is about quality of life, and I say this quite often. It's about how do we create a city that helps improve the health of the people who live here, and we do that in a number of different ways. But I think strategically, when I think of what does public health mean to me, it's about quality of life. It's about having a city where people can exercise and have access to healthy food, where they can be protected from disease threats, where they can be protected from environmental threats. So it's pretty broad. It's pretty tough to get your arms around what public health means, because I think it means something to different to everyone.
Okay.
I think a lot of it comes from your personal perspective. If you would have asked me this 25 years ago, it would have been all about environmental health.
Okay.
You know,
Sure.
but now I really look at it much more holistically. And like I said, to me, it's about quality of life and how do we get a better quality of life for the people living here.
Okay. Well, we're going to talk about a strategy that you're working on that relates to that in a little bit. But so in 2006, you became the department director.
I did. I didn't have any gray hair back then.
So let's talk about the mission of the department kind of as a whole, and then we'll talk about
Sure.
kind of the other. So we've talked about environmental health, as you said. You've got several other divisions within the department. We'll talk about those. But kind of what's the mission of the Manchester Health Department?
Yeah, you know, our mission is really about improving the health of people, making sure that we have this environment, and I use that very broadly, that's conducive to improving the health of the population. You know, and whether that's access to good health care, whether that's access to healthy foods, whether that's access to green space, whether that's getting inspectors out in the field, whether that's providing some limited care that we do provide direct services. It's really about how do we get all of these strategies, tactics, functions on the same page to say, this is why we're here, and that's what we want to do.
Okay. You're talking about a lot, and this is an interesting thing. As I said, we'll talk about this strategy that you're working on, but you're talking about a lot of things that to me don't sound like health in a sense of like, you know, getting shots or
Sure.
something like that.
Yeah.
So what resources do you have to try to bring about this holistic change in the city?
You know, we certainly receive the bulk of our, I shouldn't say the bulk of our funding, about a third of our funding comes from the city, comes from general funds. So the city's taxpayers help fund us. And, you know, the Manchester Health Department was established in 1839. So we've been around a long time. Hired its first health officer in 1885. So I think the public values the work that's done by the Manchester Health Department in helping. So, you know, our total operating budget is probably in the $5 to $6 million range when we take everything into account. So we are very aggressive about going after outside funding. Okay. And I think because we've been able to do that, we've been able to break away from a lot of the traditional public health roles. So I think the taxpayers in Manchester expect us to inspect restaurants, expect us to do disease investigations. But then we've been very creative in our funding, going after some foundations to do things like safe routes to schools, healthy corner markets. We actually get money in to help our highway department pave sidewalks so kids can get to school safely. Okay. Put up crosswalks.
Yeah. Because in New Hampshire, having a sidewalk is not a given.
No, it is not. And you know, not having any type of broad-based tax, in a sales tax or an income tax, you know, we're very careful with how we spend taxpayer dollars in the city. That's what funds us. But you know, we've gone after large pots of money from Robert Wood Johnson Foundation, from the Endowment for Health, from New Hampshire Charitable Foundation, from local funders. Granite United Way, we'll probably talk about that, just made $1.5 million investment in our neighborhood health improvement strategy. Okay. So we're pretty aggressive, and I've got, you know, great folks who do this work day in, and it's not me. It's, you know, it comes from the ground up. It's great staff here who really believe in the mission and go out and find resources to expand what we're doing.
That's great. Just quickly about governance. Who's your boss? Who do you report to?
So I report directly to the mayor.
Oh, okay.
So the city is governed by a mayor and board of aldermen. There are 14 aldermen and the mayor, and I'm appointed by the mayor and confirmed by the board of aldermen. So there's no longer term limits. There used to be term limits, and you would have to be reappointed every 6 years. But the charter has changed, and so now I'm appointed as long as I do a good job, I guess, and don't get fired. Okay. So I report directly to the mayor.
Okay. And there's a board of health in the city.
There is.
And what's the function of the Board of Health?
So the Board of Health is really serves in an advisory role. Several years ago, the city charter was changed, which took sort of some of the powers away from boards and commissions. Some boards and commissions used to have the power to hire and fire and some fiduciary responsibilities. Now they're really just advisory. But our board is interesting because by city charter, it has to be comprised of a physician, a nurse, a dentist, a labor representative, and a representative from the community.
Okay.
So at all times, we always have a nurse, a physician, and a dentist on the board, which is pretty unique because they do provide great oversight. They do provide a lot of guidance for us. It's an opportunity for us to bounce ideas off of them when we meet. We meet with them monthly. Our senior leadership team meets with the board monthly and sort of updates them on what's going on, and we get great feedback on what we're doing, what they hear in the community, and that's very helpful to us from a programming standpoint.
Okay. Let's talk about the other divisions in your department. One of the divisions is school health.
Yeah.
What does school health do?
So it's unique that in Manchester, the school nurses actually work for the health department.
Okay. That sounds unusual.
It is unusual, and it really started out years ago. Our community health nurses used to go into the schools to do the screenings. Height, weight, vision, scoliosis, if you remember, and the needs of the students have changed dramatically to where now we have a nurse in every school, and in our high schools we have 2 nurses. And it's not uncommon in a high school to see 80 kids a day in our larger schools. So they're very, very busy.
That's a lot of patients.
That's a lot of patients. And a lot of it has changed. It's not just the bumps and the bruises and the medication. There's some real, biopsychosocial needs of kids. We see a lot of substance abuse, a lot of trauma, a lot of mental health issues. So the needs of the kids have really changed through the years as well. But it is a unique model. So we have about 32, 33 staff in the schools.
Wow.
And they're busy. Everyone's busy. I hate to say people are busy because everyone's busy, but they do yeoman's work. And it's, when you have a system of care, it's not unusual on a Monday morning for there be a line of kids waiting for the school nurse because they got sick over the weekend, don't have access to health care, can't afford an emergency room. And the parent says, well, just see the nurse on Monday, and we'll go from there.
So this is they are actually kind of primary care access?
By default, I guess.
By default.
Yeah.
Okay.
They do spend a lot of time.
For a portion of the population.
Yeah.
This is the best they can get.
Absolutely.
Wow.
Yeah. And the nurses spend a lot of time trying to link families up with, primary care, with medical homes. We just did a great program where we hired through our community health center 3 community health workers, which will be in the schools working with families. The social workers in schools are overwhelmed. The administration in schools is overwhelmed. So it's another set of hands to try and help our neediest schools get resources for their families.
Now, I would call this a matrix organization in the sense that they work for you. They're employed by you, but they work for the school in the school. Why does that make sense? Why not have them be employed by the school?
The mayor asked me the same question the other day. There are pros and cons to having them here.
Sure.
Sometimes I think they feel like they serve 2 masters, and that
Absolutely.
they serve the school administration and then they serve us. I think when we look at them as an extension of public health in the schools, it makes sense for them to be aligned with the health department. CDC has some great models around school health and school nursing. From a practical, logistical standpoint, it probably makes more sense to have them employed by the school district. The school district reimburses us for their time, so we have a $2.2 million chargeback, if you will, to the school district. So from a bookkeeping and an administrative, it makes no sense to have them here. Okay. But when we look at them as almost public health nurses in a school setting, there is some synergy to have them here.
Okay. You also have a community health division, which you kind of mentioned earlier, in particular I think this was with respect to the refugee care that we were talking about earlier. Can you talk about what is the mission of the community health division?
Sure. So I almost think of them as our clinical arm. So that division is primarily our community health nurses who provide, we always talk about public health versus health care. So we don't provide health care per se, with 2 exceptions. One is around immunizations, because our goal is to get as many kids vaccinated so that we build herd immunity, which lowers the chance of a vaccine-preventable disease taking off in the community. So that's one reason we provide a direct clinical service. And the other is around STD and HIV work. So we do run STD, HIV clinics where people actually can come in and be diagnosed, be treated. And once again, we do that for a public health reason, because we certainly don't want to see rates of gonorrhea and chlamydia and other things skyrocketing in the community. People are very reluctant, if you will, to go to their primary care doc if they have an STD.
Okay.
So we are able to get people not only in here and treated, but we'll do contact investigations, find partners to make sure that they're also appropriately treated. We have a very low incidence of HIV in the state.
Okay.
In the city, we might get a couple cases a year, handful of cases a year of newly diagnosed HIV.
Why is that?
New Hampshire is a relatively low incidence state all across when it comes to that. It's interesting though, because I think with the advent of sort of the HIV drug cocktail, if you will, we spend a lot of time doing prevention, but there was sort of this mindset that, well, these drugs will take care of me if I do acquire HIV or AIDS, so I'm going to re-engage in these risky behaviors.
Okay.
But we still haven't seen it. What we are seeing right now is, not only in the city, but across the state, is a tremendous problem with heroin.
Okay, I've heard this.
And I'm concerned,
Is this something you are addressing as the public health
We're
director?
trying. We're trying. It's such a
And would you
big
do it through
problem.
your community health division or another part of it?
We certainly through our community health division, they're doing a lot of prevention, education, outreach work with IV drug users.
Okay.
My fear is that with the increase in heroin use, we're going to begin to see more hepatitis B, hepatitis C, and HIV because of the sharing of needles and other things. We don't do needle exchange in the city. It's always been a very controversial issue, as you can imagine. So yeah, I'm certainly concerned that we're going to begin to see more HIV and more Hep B and C with the increase in drug use.
Okay. Who's entitled to services from the community health division? You were saying some people would rather go there. They're embarrassed. They don't want to
Yep.
tell their primary care provider, I think I have an STD.
Right.
But who's entitled to come to your clinic?
Anyone.
Anyone.
Our doors
Okay.
are open for both immunization, HIV, STD. It's interesting when we actually survey people why they come here for immunizations, because immunizations, you can typically get at your provider's office.
Right.
And a lot of it is, I can't really afford the copay because we don't charge anything.
You don't charge at all for
We don't charge at all.
immunizations?
Correct. In New Hampshire, the vaccine is paid for by the insurance companies, and we've chosen through the years not to charge an administration fee.
Okay.
So
Okay.
people come in and get them for free.
Okay.
So copays, convenience. We run clinics one evening as well as during the day. So if someone gets their exclusion notice from school because they're not up to date, they can get in here pretty quickly. They
Right.
might have to wait in the office, but
They
versus
can get-
waiting for an
right.
appointment at their primary care doc.
Okay. Have we missed a division?
So yeah, our other division is our Division of Chronic Disease Prevention and Neighborhood
Okay.
Health. And that's really
Okay.
the newest division, if you
Okay.
will. But when you look at the work that needs to be done in public health, it's not infectious disease that kills us anymore.
Right.
It's our own lifestyles, it's chronic diseases, it's cancer, it's heart disease, and it's all based on our personal risk factors more than anything. So
Right.
do we have people that die of influenza and other communicable diseases? Yes, but when you look at what really kills us,
Yeah.
it's heart disease, it's cancer, it's things that are related to diet, that are related to smoking, that are related to lack of exercise. So we've really put a big push over the past 5 years into expanding this division of chronic disease prevention in neighborhood health.
Okay, so that leads me to the next topic, which was I had referenced earlier that you've been working on a fairly large strategy called Neighborhood Health Improvement Strategy, and it came about last year after the National Public Health Week in 2014. You announced this new Neighborhood Health Improvement Strategy. So let's talk about that. What is the Neighborhood Health Improvement Strategy?
It's really it's. Let me just step back and say sort of how we developed it was
Okay.
convening a lot of the stakeholders in the community around the issues that we were seeing. And the Neighborhood Health Improvement Strategy is just that. It's a strategy to say, if we're going to tackle health problems in the city, how are we going to do it? And the decision was made, a very conscious decision was made, that we've got to get down to the neighborhood level.
Okay.
And if we're going to get down to the neighborhood level, we want to work in the most deprived neighborhoods in the city, the ones that have the highest. When you look at the strategy, no matter what map you look at, no matter what the indicator is that we're talking about, the map always looks the same.
Okay.
We
Same
know
areas of the city.
same areas of highest need in the city, and that's where we want to begin to focus our efforts. And it's an interesting strategy in that, there are things you don't really think about. We talk about the social determinants of health. Well, if we're going to improve health, we've got to make sure people are educated. We've got to make sure people are employed. We've got to make sure people have access to care. We have to make sure that people have a safe place to live and a safe place to play and the ability to get outside. So we're looking at the strategy very holistically, if you will. It's not only about access to care, as important as that is. It's about getting into the neighborhoods of greatest need and making substantial changes to improve the lives of the people who are living there. And that's what the strategy is trying to do.
Okay. And as we talked about earlier, what you just listed off, maybe the 5 or 6 things you just listed off, only one sounded like healthcare.
Right.
Right. Everything else was kind of looking at the broader environment, looking at, even looking at some of the priority recommendations included things like supporting economic self-sufficiency, which to me doesn't sound like healthcare, but it is a part of public health.
Absolutely. When we look, and we've really tried to focus in using a community schools model. So we received some funding a couple of years ago from Robert Wood Johnson Foundation to transform 3 of our elementary schools into community schools. And what we mean by that is, how do we use this structure, the school building, for other purposes other than educating kids? How do we use it to engage neighbors and residents to use the facility for different purposes?
So this it's used during the day for the kids, but at night it's otherwise empty.
Correct. So how do we begin to put some programming in there? And give you an example, we've been doing resident leadership training at one of the schools. And once again, it's about getting people engaged in their community. And we know that some of the strategies you really don't think of as public health, but we know if we can get people employed, the health outcomes but their long-term health outcomes are better.
Right.
We know, if we can keep people educated, their long-term health outcomes are better. So it's looking at it very differently. We have we've got an issue with truancy in the city, and it's not the high school kids skipping class. It's elementary school kids who aren't making it to school, and that's a family dynamic. That's not someone just deciding they're going to cut class and go to the beach today. So we're beginning to say, how do we give families the skill set that they need to get these kids to school?
And that's a public health. So it's kind of and the reason we want them to get to school is because we know if they get educated, they'll be healthier.
Exactly.
So it reaches into your public health kind of very indirectly, but it has a real effect on health.
It has a real effect on health. And we also know that things like school are a protective factor for kids when they're exposed
what does that mean?
So when you're exposed to things like domestic violence at home, or not knowing where your next meal is going to come from, or the toxic stress of your neighborhood because there's violence and garbage and all these other things, that when we can actually get a kid in school, they become healthier because this protective factor of being out of that environment and in a safe and nurturing environment.
Okay. If for no more than 8 hours, 9 hours a day, at least it's a reprieve, an oasis maybe.
And it's interesting because we see a lot of our kids, sort of the route, they'll go to school, then they might end up at the MPAL, the Police Athletic League, and then Salvation Army Kids Cafe for dinner. There's almost a circuit that you can see a lot of our kids do every day to make sure that they can get that dinner, before heading home, or help with homework before heading home.
And what's your role and your department's, not you personally necessarily, but your department's role in kind of knitting together that what you're just describing?
I think our role is going to be the implementation of the strategy. I think our role is going to be helping to secure funding from non-traditional resources. So I mentioned earlier, the Granite United Way just made a 3-year, $1.5 million commitment to people who will implement the strategies identified in the plan. So it's not the $1.5 million is coming to the health department. It's what's your piece of the plan that you can carry out, and we'll give you money to do it, because they realize the value of the identified needs and the strategies that we want to employ. We try and use evidence-based practices whenever we can, and I thank the United Way, and I thank others who have stepped up to the plate to say, yeah, we believe in this, and we're going to put some money behind it.
Okay, so let's talk about a couple of the recommendations. One you mentioned already, which is resident leadership training opportunities. What are resident leaders? What's the vision there?
Yeah, well, the vision is having folks who want to see their neighborhoods change. We've done a lot of work with neighborhood watch groups, believe it or not, and our neighborhood watch groups aren't about patrolling neighborhoods looking for crime. Yeah, there's certainly a deterrent there, but these are folks who get together who say, how do I make my neighborhood a better place? And a lot of times these are homegrown folks that may have never had an opportunity to attend any type of a formal leadership training. So we're trying to, once again, give people additional skill sets who are already vested in their community to help make their community a better place.
Okay. Another one you have is create and coordinate sustainable healthy home system.
Yeah.
What's that strategy?
So healthy homes is an interesting concept. So we do a lot of home visiting for things like childhood asthma, childhood lead poisoning prevention, maybe checking on living conditions, some code compliance issues. And we've always, if we went in for one reason, we went in for one reason. Now we're beginning to say, well, let's take a more holistic look at the home as an environment. It's, okay, maybe we're here because your child has uncontrolled asthma, but what are some of the triggers we want to be looking for? What are some of the other issues? A lot of home visiting occurs by different agencies. So are we better coordinating with VNA, with Project Launch, with some of our other partners to say, all right, if we're in a home, how do we get the biggest bang for our buck when we're in there? And right. Looking at the home, like I said, as a much larger place than and reason why we're there for just that one visit, that's sort of our strategy. So we combine our environmental health folks with our clinical folks to say, maybe the kid has uncontrolled asthma, but it's because of the leak in the roof, causing the dampness. So it's not only the clinical side, it's the other piece. So we're really trying to look at where people live in a much different way.
Okay. You also have a mention about strengthening the focus on behavioral and mental health by co-locating providers in elementary school environment.
Yeah. I've had the opportunity for the past 6 years to sit on the board of the Mental Health Center of Greater Manchester, and the one thing we see is the number of patients continues to grow. The Mental Health Center in Manchester sees over 11,000 patients now, and I think it was 9,000 when I started on the board. When we reached out to our community schools and we said to the principal, if you could have one thing to make your school better, what would it be? And the principal at Beach Street School said, I need mental health folks in here.
Really?
When you have kids that can't learn because they have so many other things going on and they're acting out and being disruptive so that other kids can't learn, and the social worker just doesn't have the bandwidth to deal with all of this, we began to co-locate a mental health provider from the mental health system in the school.
Okay.
We used some grant money to get it up and running, and then, the goal is to make it sustainable by billing Medicaid or whatever the insurer is.
Okay.
And it's amazing. The needs of kids are just very, very different than they were years ago. And to begin to better integrate mental health in the school system, we think we're going to have a healthier population who are able to attend school.
Great. So we've talked a little bit about some of the priorities. How are you coming on them? How's the strategy going?
It's going. Certainly the investment from the United Way is going to be key to getting it off the ground.
Okay.
The city is very vested. Our leadership team is very vested. We've looked at our leadership team at the highest level. It involves the mayor, the superintendent, the police chief medical officers at the hospitals. One of the criticisms is we've got to do a better job engaging residents and neighbors in the implementation of it. So it can't be a top-down approach.
Right.
It really has to be a bottom-up approach. We've looked at the data. We do community needs assessments. We come up with, and really what this neighborhood health improvement strategy is, it's what other folks call a community health improvement plan. So it's how are we going to do it? We're looking at it very differently than saying we're going to reduce heart disease in the community by X, Y, or Z.
You definitely aren't taking a single disease focus,
No.
Which is a criticism, I think, of other public health efforts like that.
Right. It's really it's much more broad than that. We hope if we can make these bigger infrastructure and systems changes, that it doesn't matter what the disease is that we're talking about, we're going to have a positive impact.
Great. I noticed you are a fellow of NACHO. Is that?
NACHO, yes.
NACHO, all right,
Yes.
Not NACHO. The National Association of County and City Health Officials. So what is NACHO, and what does it do? So I've been living in Texas. So
that's okay.
not sure.
So NACHO is really our national organization. It stands for the National Association of County and City Health Officials. So it's almost our national organization, like APHA would be for public health, NACHO is for local health departments. I had the opportunity a few years back to go through a leadership program that they put together. It was a year-long leadership program. It was the first time I ever went to San Antonio, actually. And they picked 30 local health officers from around the country, and the requirement was you couldn't have been in your current position more than 2 years. And it was called Survive and Thrive, and it was about how to survive the challenges of being a local health official and what to expect, and really how to thrive and have a long-term career in local public health. And it's a great organization. They certainly provide a lot of updates on what's going on at the national level to us, and vice versa. There's a great opportunity for folks to sit on their different committees, boards, so that they get the input from locals as well. So it's a great organization. You can find them at nacho.org and visit their website frequently to keep up with what's going on.
Okay. So let's talk a little bit about the direct care system. And what I'm curious about is how well integrated is public health generally, in your opinion, with the direct care system, and maybe in Manchester specifically, but also kind of in your sense in general. We can talk in general, and then kind of how could that relationship be made stronger?
I think in Manchester we're very fortunate that we have a very close relationship with our healthcare delivery system. So when you look at healthcare delivery in the city, you've got 2 acute care hospitals. You've got Dartmouth-Hitchcock, which is the largest outpatient clinic in the area. We have a federally qualified community health center, federally qualified Healthcare for the Homeless project, which is actually funded through us, and then we contract out. We've done a lot of work with the system around access to care in the city. For years, our community health center was unable to keep up with the pace of need in the city. And you always see inappropriate emergency use of emergency rooms, no matter where you are in the country. And some of it is around lack of access to primary care. So a great effort was put in over many years to say, how do we improve access to care, to primary care in the city? So the hospitals have been integral parts. I joke about my hair turning gray. That was certainly one of the projects that probably added a few. But we've been able to see our community health center expand, number one, open satellite offices. They just merged with another entity called Child Health Services, which is becoming the pediatric wing of the community health center. So when you're an FQHC, you've got this enhanced reimbursement. So it makes sense to expand, to get with Medicaid expansion, with the exchange, with Obamacare. More people are being insured, and if we can get these people linked up with a community health center, as an example, it becomes a much more financially stable and sustainable model. And I think a lot of the work we did with our healthcare system was around access to care.
Okay.
We meet with them regularly. Our different divisions meet with them, so I think every division I met has a different link in with our healthcare delivery system.
Okay.
Certainly our environmental health and emergency preparedness folks work with them all of the time. Our oral health program, which I didn't mention, we actually have a school-based oral health program here, partners with one of the hospitals who has a dental clinic. Our community health staff is in regular contact with the infection control folks at the hospitals around what's going on with specific cases. And our chronic disease prevention and neighborhood health folks are really working with the healthcare delivery system around what environmental changes do we need to make to keep people healthier. There's this concept of community benefits that hospitals have to meet, and we look at community benefits more than writing off uncompensated care. It's about what are you going to do in the community to help us achieve our mission, and I think both CMC, Elliott, and our other healthcare partners have stepped up to the plate over time with that.
Great. You've been with the department for 25 years.
25 years.
How's it changed? Has mission changed? Is it an emphasis on particular activities? I mean, how does it look different than it did when you first got here?
Well, we all have computers now, which was something when I started. We had one and a dot matrix printer. I don't think the mission has changed. I think people are very true to the mission. I think how we carry out that mission has changed. I think technology has been a huge benefit for us. I remember when we had our first internet connection. and you had to sign up to use the one computer that had the internet. And now, you sit with 4 devices in front of you to be able to get access
And
to
they're all on the
instant
internet.
information. So, on one hand, I'm sad to see that people don't have research skills like we do. People don't know what a card catalog is coming up through the ranks now. But by the same token, is we have such much better access to resources and information that makes us do our job better. We always say, it's not like the fire department that can buy a bigger fire truck. I need smart people. I need people who, understand what they're doing to make a good employee. So we've grown through the years. I think we've changed our focus through the years to meet the needs of the community, and I think we're going to continue to do so. As I said, we're really making that transition now into chronic disease prevention, which is where we have to go.
My next question to you is, looking into your crystal ball, what's the future look like for public health in Manchester, public health in general?
Yeah, I think in Manchester, certainly we've got to look at these social determinants of health. We've got to get our arms around poverty, around education, around income, to if we're going to have long-term impacts. From the department standpoint, we're always going to carry out the tasks, if you will, that we need to do. But I think how we tackle them, how we fund them, how we utilize our resources are going to change in the future, and a lot of it is going to be driven by the neighborhood health improvement strategy.
Okay. How has your leadership of the department been shaped by your experience here, for having been here and having grown up in Manchester, and having been in the department for as long as you have?
There's a couple things. I think I like to hire folks with a very strong work ethic.
Okay.
I don't want to micromanage people. I don't micromanage people. I don't want to babysit people. I want people to be committed to the cause, have a strong work ethic, and day in and day out do what's right. I try and I do less public health and I do more administrative work by default. Mm-hmm. So I try and shield my employees, the folks who I get to work with, from some of the nonsense that goes on around budgeting and politics, and because that's a lot of what we have to deal with. Sure. And I want folks to be able to be, isolated from that and let me handle that, and you folks handle what you're committed to and what you're doing. So I think that's one of the things that has its pros and cons through the years. Is I still remain very active in public health. I don't want to sound like I just push a pencil around all day, but I think giving people the ability to go out and do their jobs and be shielded from some of the other work that goes on makes us a stronger department.
Okay. Did you have a mentor coming up through the program? Did you have mentors perhaps? And
I had the opportunity to really work for some great folks coming into the department. Fred Russick, who was the previous public health director, I certainly learned a lot from him and by watching him. Rich DiPentima, who was the deputy director at the time as I was sort of coming up. Just 2 brilliant guys, public health wise. And you learn, you watch, and I like to kind of watch and learn and not necessarily follow someone's style, but learn from their style and develop my own style based on what I think works. So, Fred and Rich were great to work for through all these years, and you learn a lot about how to handle the different aspects of the job, from dealing with a board of mayor and aldermen to CEOs of hospitals to neighborhood residents. And I think that's one of the beauties of this job, is you get to do that.
It's quite a diversity of
It's a great diversity. And that's one of the things I love about this is, people say, what's a typical day look like? I couldn't tell you. Because there's really no such thing. Because it will literally be, being out in the community and talking to all segments of society. Because if we're going to improve the health of the people of Manchester, it's going to take an across-the-board group to do it.
Kind of wrapping up, what advice would you give to a young person who's thinking about public health as a career field?
I would strongly encourage them to continue their studies in it. I think understand what you're passionate about. I think one of the beauties of getting into public health is you've got a tremendous number of opportunities. Understand what you're passionate about. If you're passionate about environmental health, take that track. If you're passionate about working with people in a non-clinical setting, take that path. So whether it's undergraduate or a graduate degree in public health, is going to open up a lot of doors for you, but follow your passion.
Okay. And what kind of specific preparation would make you ready to come in and be an entry-level person in the Manchester Public Health Department?
Yeah. To me, it's about having the right attitude more than anything.
Okay.
So, as I said, we want folks when they come in to be passionate, to be able to interact with others. Sometimes I'll go talk to groups of graduating students, and my advice is I don't want to hear the word like or amazing every other word that comes out of your mouth. So one thing is amazing, not everything is amazing. And using the word like drives me crazy. But I want people who can interact with others on a professional basis, that can handle diversity, because the challenges of working in public health change every day. So being able to go with the flow at times is critical. So I want someone with a sound education. I want someone with good interpersonal skills.
Okay, great. Well, any parting thoughts? We wrap up here. Any thoughts for the?
I've been very fortunate
Yeah.
to have a career in public health. I've been very fortunate to spend 25 years here at the health department, and I think anytime you come into an organization, if you leave the organization a little bit better than you found it, then that's a success. And I think when people move on, and we've had great people move on to other jobs and other careers, and I say if someone has learned here and has been able to move on and make an impact somewhere else, that's okay. We've done our job, and I think we're always ready to meet the challenges that lie ahead, and looking forward to doing it for a few more years.
Awesome. Thank you so much for giving me the interview today. I've enjoyed talking with you about it.
My pleasure. Thank you.
Hopefully we'll be able to follow up at some point and hear more about your strategy and
Yes,
how it's going.
we would be glad to do that, because I think we're going to see some real successes.
You've been listening to the Health Leader Forge, a production of the College of Health and Human Services at the University of New Hampshire. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll see you again in about 2 weeks.